Hello everyone, so this is Sandra here. So in today's video, we are going to discuss about legal and ethics. So that's quite a kind of very little dry topic. But anyways, let's look into the topic. And the first topic is advance directive. And what is an advance directive? They are legal documents that allows client to make decisions about their future medical treatment in case the client later becomes incompetent. Okay, so it's about their future medical treatment. You understand? So they're legal documents that allows client to make decisions about their future medical treatment. Okay, so if I'm I'm not having any problem, but then I'm making an advance directive for my future medical treatment purpose. So anyone can make it any time for their future purpose. So that is an advance directive. So it can be used once I become incompetent. Okay. So we are telling about advance directive, which is only related to healthcare decisions. We are nurses and we are going to talk about only healthcare decisions. Alright, the most common forms are living will and durable power of attorney. And what is a living will? Alright, that declares client's wishes related to specific situations. Okay, that's the client's wishes related to specific situations like life-sustaining treatments, CPR, intubation, mechanical ventilation, etc. If I don't need to be intubated, I don't wish to be intubated when I'm at my end of life, I don't want to be intubated. So I am going to state that in my advance directive that I don't want to be intubated, and that's what is called as living will. All right. And the next one, power of attorney. So what's a power of attorney? A client designated decision-making personnel who can advocate the client as needed and is flexible. And so power of attorney is somebody or any personnel other than the client who is designated by the client. Okay. In this living will, the client makes the decision. All right. In both of the situations, the client makes the decision. But then the living will is the client himself declares wishes. But then in the power of attorney, the client designated decision-making personnel is another personnel who is designated by the client is going to advocate the client as needed, and it is flexible. Anytime it can be changed. All right. And it can be a medical power of attorney who makes medical decisions, and it can be also a financial power of attorney who makes the financial related things. And it only goes into effect if the client goes incompetent. Remember, it only goes into effect if the client goes incompetent. If I'm all right and I have appointed a power of attorney, that does not mean that he can make decisions whenever I am competent. It comes into action only when I am incompetent or if the client is incompetent. So that's about advance directive. That's something, decisions related to the future medical treatment, which is made by the client while he's competent for related to the future medical treatment, which has to be used or which has to be come into action when he's incompetent. So that's about advance directive. All right. Let's go into the next one. So if there is a DNR board, okay, anytime if there is a do not resuscitate board. What is a DNR board? A do not resuscitate board, okay? Stop the resuscitation. If any time you are seeing somebody, resuscitating the patient who already has a DNR board, and you have to tell them that stop the resuscitation. And anytime you're failing to stop an advance directive in a timely fashion can result in legalization. So it can finally or eventually result in legalization. So this is very serious. So you have to stop if there is a do not resuscitate board. You have to stop. Okay? And the spouse or any other person cannot make any decision for the client if the client is competent. If I am competent, I can make the decisions. I don't want anybody else to make the decisions for me, right? All right, so I don't want my spouse or I don't want any other person to make any decisions for me related, let it be related to any financial issues or let it be related to any, medical things, nothing. I don't want anybody to make decisions for me. I can make myself. So while the client is competent, you don't want to ask anybody else. Being a nurse, you can just ask the client itself because he is competent, he or she is competent. So you can definitely ask themselves to make a, decision. All right. And what is an informed refusal? Okay. This is the next one. That is an informed refusal. So knowing the risk and benefits of decision, including potential of latent infection or damage. So that's an informed refusal. So the client knows, or we have explained everything about the, let it be any disease condition or anything else, any procedure. So we are going to inform everything to the client, the risk, the benefits of the decision. All right, for example, we're just, telling the client that he or she has to undergo a procedure, but then he or she is telling that I don't need to do the procedure right now. And then, so we have to explain everything. We have to tell them the risk of the procedure, the benefits of the procedure. Maybe that will be, even though if it can be a life-saving procedure, if the client tells that I don't need to do the procedure done now. So then we have explained everything from the nurse's part. We have explained everything, the risk, benefits, and every potential of latent infection or damage. Everything we have explained. Even though the client is telling that, even if the client denies to do the procedure after explaining everything, then you have to. That is known as informed refusal. We have informed everything to the client. Okay, we have informed the risk, we have informed benefits, and everything we have informed. And then also the client is telling that I don't need the procedure, I don't need any treatment. Then that is known as informed refusal. Okay, so that's all. Yes. And now that's all about advanced directive. And now the ethics. Ethics is a branch of philosophy which is concerned with the distinction between right and wrong based on a body of knowledge, not based on only on options. Okay. So just for your side note, I'm just explaining. All of us have ethics, right? So what are ethics? Haven't we any time thought about what is an ethics? Okay, so ethics is just a branch of philosophy. This is not very important for your NCLEX, but then you have to know what is ethics before studying what are the ethical principles related to nursing. So just for the side note purpose, so ethics is concerned with the distinction between right and wrong. Okay, it's a distinction between I know what's right and I know what's wrong based on a body of knowledge. Okay, so there is a distinct body of knowledge already available, and based on that I know what's right and I know what's wrong. Okay, and it's not just based only on options. Okay, so that's known as ethics. So yes. And we have different ethical principles. And that they are very important from NCLEX point of view. And so you have to remember all this. One of the main ethical principles is autonomy. What is an autonomy? A right to make decisions oneself. Okay. So yes, autonomy means a right to make decisions oneself. I can make decisions about something regarding to myself. Any patient can make decisions about himself or herself. Okay, so each one has his or her own right to make decisions for himself or herself. Okay, so that is known as autonomy. Okay. And what is non-maleficence? Non-maleficence, that's the next one. Non-maleficence, doing no harm, protecting clients who are unable to protect themselves due to physical, mental conditions. Okay, so just understand what is non-maleficence. Non-maleficence is doing no harm. Okay, We don't want to harm the patient. We are nurses. We don't want to harm the patient. So you should not do anything knowingly or unknowingly. You should not harm the patient. Doing no harm to, not just to the patient, not anybody else. We don't want to do any harm. And we have to protect clients who are unable to protect themselves. Who are unable to protect themselves. Who are unable to protect themselves. So that means maybe somebody who's incompetent, maybe somebody who's physically or mentally retarded, such people. So they don't know what is right or what is wrong or what has to be done. So such things they don't know. So we don't want to misguide them or we don't want to harm them, and we should not harm them. So that's basically non-maleficence. Okay. So we have two ethical principles here. The first one is autonomy, wherein the patient can make decisions himself or herself. And the second one is non-maleficence, wherein doing it just means doing no harm. We don't want to hurt or harm anybody. Protecting clients who are unable to protect themselves due to physical, mental conditions. So that's all. Yes. And the next one is beneficence. Okay, beneficence. It's to do good to others. Okay, we have to be, we should be we should be benefited to others. We should be useful for others. Okay, what does the benefit? What does a benefit mean? The word benefit. That is something useful or something beneficial. So that's justice. This is beneficence. That means to do good to others. We have to always do good things to others. So we don't want to harm them or just do good things to others. Okay. And the next one is justice. Justice is treating everyone equally. And this is an NCLEX very, very favorite one. Treating everyone equally. Being a nurse, we don't want to show any partiality. We don't want to, give a particular treatment to one person for so much time and then, ignoring the other patient. That's not nice. We have to treat everybody, every client equally. Okay? So that is justice, a simple one. And the third one, fifth one, veracity. Telling the truth as a fundamental part of building a trusting relationship. Okay. I'm sorry. Yeah. Veracity means telling the truth. Okay. So we have to tell the patients the truth. We don't want to, give false assurance to the patient. So we have to tell the patients the truth. Whatever the truth is, we have to tell the patient. That does not mean that if a patient is in a critical condition, we don't want to go directly tell to the patient that you're going to die in next few months. That's not the right way. But then we have to convey it appropriately, either to the family members or, how it has to be, how it has to be conveyed, and that way maybe through proper through proper communication techniques, you have to convey things to the patient. Okay, always we have to tell the truth. Okay, that's it. It's maybe directly or indirectly, depending on the situation, you have to just tell the truth as a fundamental part of building a trusting relationship. Whenever you tell the truth, the patient is going to build a relationship of trust towards you. All right. Okay, I'm sorry. And the next one is fidelity. So fidelity is exhibiting loyalty and fulfilling commitments made to oneself or others. Okay, so they just, if I have made a commitment to somebody else, so I have to fulfill that. So that is fidelity. So if I have told to a patient that I'll come here by 8 o'clock, or I'll see you by 8 o'clock, or I'll give the medicine at 2 o'clock, we have to fulfill the commitments that we have made. We have to be loyal, okay? We have to be loyal and we have to fulfill the commitments also, okay? So that is fidelity. And the next one, accountability. Accountability is nothing but refers to accepting responsibilities for one's actions and admitting errors. Okay, so it refers to accepting responsibilities for one's actions and admitting errors. Okay, if I have made some mistake, okay, let it be knowingly or unknowingly, I have to accept that's my mistake and I've just made it. Okay, we can't do anything if once we have made a mistake. Okay, it's not that you have to always make mistakes, but just try not doing mistakes. But then if any mistakes happens by chance, you have to accept that it's my mistake. So that's known as accountability. And not just mistakes, even responsibilities also. We have to, accept our responsibilities, that I have to look after 2 patients. That's my responsibility today. Or that's a, duty of myself on this shift. So I have to look after this patient. So that's my responsibility. I have to give them medicines. I have to look after them. I have to give them a bath. So everything else. So you have to accept the responsibilities and actions and admitting errors. Okay, you have to accept whatever you have done. All right. And the next one, confidentiality. This is something very familiar, like justice. So confidentiality is nothing but the information shared with the nurse is to be kept as a secret. Okay, if the patient has told to you something very confidential or something related to his personal life, it's not that you have to, expose it to everybody around you, or you have to share this thing to every others in the shift. You have to, if he or she or the patient has told you something very, secretly, you have to keep it as a secret. If it is something related to the, medical condition or something very bad, you can just tell the patient that it has to be told to the doctor or the HCP. Okay, so if it is to be kept confidential, if the patient tells you as a secret, you have to definitely keep it as a secret. You don't want to tell it to everybody else. Okay, so these are just some of the principles, ethical principles: beneficence, doing good to others; justice, treating everybody equally; veracity, telling the truth; and fidelity, exhibiting loyalty and fulfilling the commitments that you have made. And the accountability refers to accepting responsibilities for one's actions and admitting errors. And confidentiality, keeping secrets as secrets. Okay. All right. And the next one. So the next topic is ethical dilemma. What is an ethical dilemma? When does this thing, this dilemma occur? Okay. So when does usually a dilemma occur? When something we plan for something, but then that was cancelled, there will be a dilemma. Okay. So that is known as a dilemma. So that is just, we'll look into ethical dilemma. So occurs when there is a conflict. So yes, when there is a conflict between 2 or more ethical principles. Okay, we have learned many principles, maybe like 6, 7, 8 principles we have learned. So when there is a conflict between 2 or more principles, that is known as, or there occurs the ethical dilemma. No correct decision exists. Okay, so maybe from the justice point of view, that will be correct, but then from the veracity point of view, it will be wrong. So there is no correct decision exist. There is no correct decision exist. It is a conflict between the, ethical principles. Okay, and the nurse must make a choice between 2 alternatives that are equally unsatisfactory. Okay, and the nurse is forced to make a choice because there is nothing correct choice between 2 alternatives. There are 2 alternatives. They are both unsatisfactory. They are both incorrect. That are equally unsatisfactory or incorrect. The nurse has to make a choice. Okay, the nurse has to make a choice. Then only the treatment or any procedure that will go on. So she has to make a choice. So both are unsatisfactory, but then she's forced to take a choice. So there occurs, or that situation is known as ethical dilemma. All right, hope you understood. Yes. And the next one, negligence and malpractice. This is another topic. So what is a negligence? These two words you might have been heard all through your lifetime. This is not something related to the medical terms or something. It's just, what is negligence? It's a conduct that falls below the standards of care. The nurse who does not meet appropriate standards of care may be held liable. So negligence is a conduct, or conduct is a behavior. Okay, behavior that falls below, there is a standard of care, or there is a set standard of care. Okay, so something that falls below the set standards of care is known as negligence. Okay, any behavior that is way bad than the set standards of care, it does not reach the standards of care, is known as negligence. A nurse who does not meet appropriate standards of care, there is a set standards of care. Unknowingly, I have made a mistake, or I'm not giving care appropriately, meeting the standard of care, it is known as negligence. Okay, so it's very serious, okay, because somebody who does not meet the appropriate standards of care may be held even liable. Okay, she can be even put into jail. All right, and what is malpractice? Determined if the nurse owed a duty to the client and did not carry out the duty, and the client was injured because the nurse failed to perform the duty. Okay, malpractice is something that we knew, or the nurse knew. Okay, determined if the nurse owed a duty, or the nurse was supposed to do a duty or to perform a procedure for a client. The nurse was supposed to give a particular procedure or particular care to the patient, but then she could not carry it. It's not that she could not, she did not. Okay, she did not carry out the duty. Knowingly, she did not carry out the duty, and the client was injured. Okay, the client had something very bad. Okay, the client was injured. If only the client was injured because the nurse failed to perform the duty. Okay, so then it is a malpractice. Okay, in simpler words, the severe case of negligence is a malpractice. Okay, so yes, determined if the nurse owed a duty to the client, so she was supposed to do or perform a duty, but then she did not perform the duty. As a result, the client was injured. Then it is known as malpractice. Okay, so it was injured to the patient, or it was badly affected to the client. So then that is malpractice. Okay. Yeah. Okay. And now we are going to, read something very interesting, that is the Good Samaritan law. Okay. So you might have heard of a Good Samaritan in the Bible. So there is a law called the Good Samaritan law. All right. So let's look into what is a Good Samaritan law. So that prevent civil action against nurses who stop of their own accord something not part of their job duties, to help individuals after an accident. Okay, so this law is just to prevent. Okay, it is to prevent. It is something good for nurses. It is to prevent civil action, any action against nurses, okay, who stop of their own accord, or who stopped their own, something which is out of their job or out of their duty, something which is not part of their job or duties, to help individuals after an accident. Okay, she can help a patient or individual after an accident. Okay, and that is, this law is to prevent civil action against such nurses. Okay, the nurse cannot receive a payment. She cannot receive a payment. She cannot apply pressure to prevent arterial bleed. Okay, do not apply that. You might be knowing it. Do not apply pressure to prevent an arterial bleed. And the nurse should hand over while shifting to any paramedic, not necessary to accompany to the hospital. The nurse should actually, hand over the patient. She must stay with the patient till that time. She has to, hand over the patient to the paramedic. Maybe, somebody who comes in the ambulance or somebody else. So to the paramedic, we have to shift the patient to the hospital. From the accident site, the nurse shifts the patient. But it's not necessary that she has to go with the patient. Okay, she can be, just hand over or shift the patient. Okay, to the hospital. She does not want to accompany to the hospital. So that is the Good Samaritan law. Okay. So yeah, the next one. Okay. Another topic related to this legal and ethics is organ donation and transplantation. A client has the right to be an organ donor and to refuse an organ transplantation. Of course, I am making decisions on myself. I am competent. Okay, so if the client is competent and he or she can make decisions, the client has the right. Be told, the client has the right. The client has the autonomy right to be an organ donor. Okay, the client can be an organ donor. I can donate my organs. That's my wish. Okay, so I can be an organ donor, and I even can refuse the organ transplantation also. Okay, I can refuse an organ transplantation. I can be an organ donor. Okay, I can do both of these things. I can either receive or I can even donate also. An individual who is 18 years old may indicate a wish to become a donor on his or her driver's license or in an advance directive. Okay, so this is something regarding to the teenage or somebody on 18 years of old. So somebody on 18 years old is indicating a wish to become a donor. Okay, so we can just have her drive his or her driver's license. We can either catch up her driver's license, or we can just take it in an advance directive. We told, what is an advance directive? Something we are writing for our future plans, something related to the health. Okay, so that's an advance directive. So somebody or an individual who's 18 years old must show their driving license, or with an advance directive, they can definitely, donate their organs. Some organs such as heart, lungs and liver can be obtained only from a person who is on mechanical ventilation and has suffered brain death, whereas other organs or tissues can be removed several hours after death. Okay, there are certain organs. It's not that once you're 18 and you can donate anything and everything you want. There is nobody who donates everything. But then, yes, some organs, especially the heart, lungs and the liver. Okay, heart, lungs, liver can be obtained only from a person. Okay, I can take heart, lungs and liver only from a person who is on mechanical ventilation, who should be on mechanical ventilation, and has suffered brain death. Okay, Okay, whereas other organs or tissues can be removed several hours after death. Okay, so these three things, heart, lungs and liver, you can only obtain from a person who's on mechanical ventilation, who's on a ventilator, or who is ventilated mechanically. Somebody on ventilator or on a mechanical, somebody on breathing with the machineries. That's a mechanical ventilation, and has suffered brain death. Okay, he must have suffered brain death also. And whereas other organs or tissues can be removed several hours after birth, and other tissues or things can be removed several hours after death. Okay, so that's about organ donation and transplantation. Now, there is a thing called local organ procurement services. That is also known as OPS, which is the Organ Procurement Services. So that is known as OPS. OPS are notified for every death per hospital protocol. Okay, so depending on the particular hospital protocol, every hospital has a particular protocol. So depending on that, every death per hospital, every death per hospital has to be notified to this Organ Procurement Services. If the client is deemed appropriate, or if the client is he has an advance directive, or he had made a decision of giving up all his organs. Before itself, he has written on his advance directive that he is going to give all his organs. So that is an appropriate donor. Okay. If the client is chosen as an appropriate donor, the OPS collaborate with the hospital staff in approaching the client's family about organ donation. So all the nurses has to do, all we have to do is what? We have to, whenever there is a death, we have to, inform these people, this Organ Procurement Services. So they'll come and they'll, if the patient is an appropriate donor. If the patient is an appropriate donor, soon after the death, we have to notify those Organ Procurement Services. So they'll come to the hospital and talk to the family, the client's family, about organ donation. So that's it. And cardiac support and respiratory support continue as organ donation is discussed. Okay, so cardiac support and respiratory support continue as organ donation is discussed. Life support is only withdrawn if the client is not a candidate for donation due to physiological reasons for the client family, or the client family does not consent. So whenever there is an organ donation, or if he is an appropriate candidate for an organ to be chosen as an organ donor, then the cardiac support, we have to give all the drugs and everything else. The cardiac support and the respiratory support, the mechanical ventilation and everything else continue. We have to continue them. We should not stop them as organ donation is discussed. Okay, on the time during which we are discussing the organ donation with the services and the people come and talk to the family, during all this time, we should not discontinue, or we should not stop or cessate the cardiac support and the respiratory support. So, and the life support, and this is basically the life support, is only withdrawn if the client is not a candidate for donation. It's only stopped if the client is not a candidate for donation. Maybe due to physiological reasons, or the family does not consent. Okay, it can be either maybe some physiological reasons, the person's, heart or liver cannot be transplanted. If there are such situations, then you can definitely, stop the cardiac support and respiratory support. And, or if the client's family does not consent, or if they're telling that I don't want to do this, then you can definitely stop them. Okay. So that is something related to organ procurement services. Okay. And then next one, yes, this is very important from NCLEX point of view, and yeah, every nurses should know about this. This is something we have to do on a daily basis before every procedures, or before everything we have to do this. We have to get a consent. What is a consent? What is a consent? Consent, okay, what is basically just what is a consent? The word consent, we have to take, or we have to ask permission. That's a consent. Okay, we have to take permission before doing anything, or any time or anything. While before doing something, we have to ask the person's permission that can I do it. Okay, so in medical terms, it is known as informed consent. Informed consent, break it just. Informed means we are going to inform the patient, and the consent means we are going to ask for permission. So the client's approval, okay, the client's permission to have his or her body touched by a specific individual, okay. So it's the client's approval that, okay, you can do this procedure on me, you can do the scan on me. So that is informed consent. Legal documents that indicate the client's permission to perform surgery, treatment, or procedure. We take these consents on everything, maybe a surgery, maybe a treatment, or maybe a procedure. Okay, in all such cases, we take the consent of the person. We have to explain. It's not we are going to take it. Actually, doctor will explain everything. Remember that nurses are not going to take the consent. Okay, so yes, doctors are going to explain everything. Doctors, all we have to do, all the nurses has to do is that we have to watch the patient as assigning the consent or not. Okay, so that's our duty in this consent. So consent is basically a legal document that indicate the client's permission to perform surgery, treatment, or procedure, or give information to a third party. Okay. So I think I've just discussed this, yes, to a third party. Okay. So even I have to, I have to discuss something related to my patient to his family members or somebody outside, or the patient is competent and I have to tell about him or her regarding his conditions to everything to his family members, and I have to definitely get a consent from the patient. Okay, first I have to get the consent from the patient, and if the patient is permitting me, only then I have to give information to a third party. Okay, so that is informed consent. And the client must be informed about the surgery, benefits, and risk Okay, so this is basically what all are explained in the consent. Maybe the, benefits, risk, consequences if not having the surgery, treatment options, and the name of the healthcare provider performing the surgery. Nurse should make sure the client understood the procedure and verify the signature. Okay, so in an informed consent, there will be benefits and risk. Okay, so this will be explained in the consent. What all benefits will be there once if you do the surgery, what all benefits will be there, and what all risks are there. Certain surgery has very fatal risks are there even. So we need to inform everything to the client before the surgery itself. Okay, because if there is a fatal complication and then we are not going to tell it to the patient, and after the surgery everything goes wrong, then it's not our fault or it's not anybody's fault. So we have to they'll definitely blame on us. So we have to, for that purpose, we have to take a consent or take an informed consent, and that will be, everything will be stated in that the surgery benefits, risk, consequences, and if not having the surgery, the treatment options. Okay, so there will be some things, maybe some conditions. There will be some conditions where if the patient does not want to take a surgery, so he or she is telling that I can just do something else, or I can just take the tablets instead of the surgery, then we'll even explain that in the informed consent. In case if you're not taking the surgery, then you can definitely go with these options or that options. Maybe you can take the medicines instead of taking the surgery. There is an alternate options. All those options, everything has to be explained to the patient. Okay, and the name of the healthcare provider performing the surgery. Okay, so who is going to perform the surgery? The healthcare personnel, Dr. XYZ is going to perform the surgery, so that has to be also stated in the informed consent. Nurse should, okay, that's important. So what's our role in this consent? The nurse should make sure that the client understood the procedure. We have to make sure that the client understood the procedure. We have to ask them, did you understand the procedure? Okay, and we have to make sure that the client, maybe while Okay, maybe while telling, the doctor will tell everything and the patient nods everything else. I mean, he or she might be just nod the head, but then we the nurses has to verify the signature, and also we have to make sure that the client understands everything. Okay, so we have to make sure the client understands the procedure and verify the signature. We have to verify the signature. Okay, that's the nurse's role in an informed consent. Okay, we have to verify and we have to make sure the client understood. Okay, never get misled. This doctor is going to explain everything and we are just going to verify the signature and making sure that the client understood everything related to the procedure. All right, and there are different procedures or different types when we are going to take the consent. On a blood transfusion consent, or from the name it's very clear what is a blood transfusion consent. While before transfusing the blood, or it can be a surgical consent while doing before the surgery, and it can be a research consent. So that is, there are certain researches and everything else. So in that cases, there is research concern. We have to just go and take away all the information from another person. We have to take a consent from them that he or she is willing to do the research or willing to participate in the research. So that's a research consent. And there is immunization consent. Okay, he or she is interested in taking the vaccination or taking the immunization, so that consent. And there's also an admission agreement, okay, which is made during the time of admission. Okay, so these are the things related to consent or the informed consent. Okay, so there are 3 principles for an informed consent. First thing, the surgeon explains the diagnosis, planned procedure with risk and benefits, expected outcome, alternate treatments and prognosis without surgery. Okay, the surgeon is going to explain everything, and he's going to, as I've mentioned in the on the previous slide, I've told everything, so you can just understand. He's going to explain the risk, benefits, expected outcome, alternate treatments and prognosis without surgery. The prognosis, so the surgeon is going to explain, okay, if you're not going to do the surgery, your prognosis is poor, or if you're doing the surgery, your prognosis is high, or after doing the surgery, you have a fatal effect. Okay, so such things the surgeon explains, not the nurse, the surgeon explains. The surgeon explains. Okay, the client indicates understanding. So that's the second step. The client indicates understanding. The client tells, okay, I'm understanding everything. I understood everything. So the client tells verbally, okay, I understood everything. So the client is going to state that. And after that, the client is the third step, we are going to verify the third step, client is competent and gives voluntary consent. If only the client is competent, he or she can give a voluntary consent. If he or she is not competent, definitely they cannot give the consent. Okay. The nurse witnessed client's signature if sedated and unconscious and require more signatures. The client's medical power of attorney or legal guardian or next of kin should be contacted. So on the fourth step, the nurse witnesses the client's signature. The nurse is going to witness the client's signature, and that's a fourth step. And after that, if the client is sedated, we told only the competent client could give the voluntary consent. And if the client is sedated or if the client is unconscious and require more signatures, okay? If the client is sedated or if the client is unconscious, or that makes sense, right? If the client is not competent and require more signatures, the client's medical power of attorney. We have talked about that. Who is a medical power of attorney? A person who is going to make plans about make decisions about the patient, or a client designated personnel. Okay, so this medical power of attorney or the legal guardian. Okay, who's a legal guardian? A parent or somebody next of kin, somebody who is closely related to the patient or should be contacted. We have to contact them and take more signatures if required. Okay, so these are some principles of the informed consent. The steps of the informed consent. Okay. And this is the HIPAA Act, or the Health Insurance Portability and Accountability Act. Okay, the Health Insurance Portability and Accountability Act. Okay, so that is HIPAA. It's a federal law that required the creation of national standards to protect sensitive patient health information from being disclosed without the patient's consent or knowledge. We're not supposed to, disclose the information related to the patient to anybody else. We are not supposed to tell anybody or anything related to the patient to anybody else. Okay, so HIPAA is there to stand for the patient, or HIPAA has set certain standards stating that no information or nothing related to the patient should be disclosed with the patient without the patient's consent or knowledge. We should not disclose anything, and HIPAA has a rule stating that. And there should not be any gossiping. Okay, and sharing. There should not be any sharing of PHI, and there should not be improper disposal of records. Okay, and we should not, improperly dispose all the records anywhere and everywhere we need. We have to properly dispose the records, because the records contain all the necessary or all the information regarding the patient. So we don't want to dispose it anywhere as we need or just throw it away. We have to, dispose it accordingly, keeping unsecured records. Okay, we should not keep any unsecured records also. So this is the Health Insurance Portability and Accountability Act, or the HIPAA Act, and this is even an NCLEX favorite. Okay, the healthcare worker should not access medical records of clients not currently assigned or discuss client diagnosis with non-essential personnel. Okay, a healthcare worker, anybody, a nurse or a HCP or anybody else, should not access medical records of clients. Okay, for instance, I was assigned with a patient yesterday, and today I'm not assigned with that patient. I should not go or I should not discuss with anybody related to that patient's diagnosis, or I should not go and look into that patient's chart or what is happening to that patient or anything. I should not know more about the patient if that client is not assigned to me today. Okay, so the healthcare worker should not access medical records of clients. Okay, that is, I should not access medical records of the clients not currently assigned. He or she or the client is not assigned to me today. He was assigned yesterday, but not today. So today, I don't want to look at the records of the clients who was assigned to me yesterday, currently assigned, or discuss the client diagnosis with non-essential personnel. Somebody I should not discuss these things with a personnel other than the healthcare team, or I don't want to discuss it with somebody in my family or somebody in his family, the client's family. So I should not discuss it with anybody who does not want to know this information essentially. Okay, certain incidental disclosures are allowed if reasonable precautions are taken. Okay, if but certain incidental disclosures at times we can disclose, but terms and conditions apply. Okay, allowing medical record to a healthcare worker only when necessary to perform job duties. The healthcare worker can is allowed to take the medical record only when necessary to perform the job duties. If I want to perform a job duty to a client yesterday assigned to me, or the person is asking my help, so that I just want to know a brief thing. I just want to know a little quiet brief things about the patient before doing a particular procedure. So then I have to know little things about the patient. So then I can for performing the job duties, it is necessary for me to know certain things about the patient. So that is it. And employers' room dividers or curtains in semi-private space. Okay, and that's another thing. Okay, there are employers room, all the nurses or all the LPNs or everybody sit together in a room, not in a room, there are different rooms. In those rooms, in any employer's room, dividers or curtains should be there in any semi-private space. Okay, so that's about some things related to, some important points related to HIPAA. Okay. Avoid discussions about client and conditions in public area. We don't want to discuss about my client in public area. Okay. And listing, I don't want to, discuss with my friends. I don't want to get back home and discuss with my friends about I had such, such patient called XYZ and he was diagnosed with ABC. And I don't want to think, I don't want to tell all, or I don't want to share everything with with my friends or family. Okay, we don't want to discuss about these conditions in public areas. And listing only last names in the whiteboard of nurses station. We should only list the last names in the whiteboards of the nurses station. Last names should only be put up in the whiteboards of nurses station. Placing communication whiteboard where they are least visible to the public. Okay, we have to place the communication whiteboard. This that will contain a brief or very little things about the patient. So such whiteboards should only kept where it is least visible to the public. Okay, there in a hospital there will be, or just outside the ward there will be so many patient parties or patient relatives. Everybody else will be will be there outside the outside the ward, so that we don't need the public, or we don't want anybody else to see our patient's charts, or not the chart, our patient details. So we have to place communication whiteboards where they are least visible to the public. Communicating with low voice in semi-private room. Okay, we have to communicate in low voice. Okay, we don't want to scream there. Actually, we don't want to discuss anything about the patient in those semi-private rooms. Okay, so maybe if the client has a semi-private room, in that case, yes, we have to discuss about our client, so that in such situations we have to communicate with low voice. There is another patient also, so that patient and his relatives does not want to know about our patient or this particular patient A. Okay, so in a room there are two patients, A and B. So while communicating about A, or while discussing about treatment things, related to the treatment of patient A, we don't want this patient B to overhear everything related to patient A. Okay, so that is this communicating with low voice in semi-private room. We have to communicate in a very low voice, so that nobody will overhear anything related to any particular patient. Okay, and this maintenance of confidentiality. We should not discuss any client issues with other clients or staffs uninvolved in the client's care. Okay, we should not discuss client issues with other clients or staffs uninvolved in the client's care. Yes, that's something we have discussed earlier. Not sharing healthcare information with others without the client's consent. Yes, we know. So we have to maintain the confidentiality. We have to we should not discuss any client issues, and we should not share any healthcare information without the client's consent. Okay. Yes. Yes. We have to keep all the information about the client private, and not relieving it to someone not involved in the care. Yes, we have discussed everything else before. Discussing the client information only in private areas, and protecting the medical records from all unauthorized readers. Okay, this unauthorized readers. Okay, somebody other than people who need to know about need to know about the patient. Somebody other than the personnel who need to know about the patient. Okay, so they are unauthorized readers. We don't want unauthorized readers or these kind of people to read all the medical records. So we have to keep it in a safe place where nobody is going to see the records of our patient. Okay. And there is another thing called a PIP EDA. So that's a Personal Information Protection and Electronic Documents Act. Okay, Personal Information Protection and Electronic Documents Act. Okay, under HIPAA and this PIP EDA, a client overhearing discussion with other client is not a violation. It's not his fault that it's his fault, but it's not a violation. Okay, if he overhears a discussion with other client, okay, if client A is overhearing, it's us, or it's the nurses or any healthcare professional, to maintain, maintain confidentiality. We have to speak in a low voice and such things. We have to do everything so that nobody is going to overhear the patient. So it's not a violation that if a client or if any other client is going to overhear discussion with other client is not a violation. It's not a violation. Calling client by last name and first name at public waiting room is okay. It's okay. Okay. So we can call the clients by last name and first name and public places or public waiting rooms. It's totally okay. And any employee can give socially acceptable well wishes to the client. Okay, we can well wish the client. We can tell good morning or good night, good morning Mrs. Smith, or we can just tell good afternoon, anything. It should be socially acceptable. Remember the word, it should be socially acceptable. Okay, it should be socially acceptable. That's what you have to note. Okay, nothing which is socially unacceptable. All right. And what are legal safeguards? So when should we, this incident reports, when should be taken? All incidents and accidents that cause actual or potential harm to a client or employee or visitor must be reported. Okay, so when should we take an incident report? Okay, any incident or accident, it can be an incident that took place or it can be an accident that happened, so that causes any actual or potential harm. Okay, that's what, any actual or potential harm to a client or employee or visitor must be reported. Okay, it should be reported. Any file in institution computer document using electronic form. Okay, so what we have to do is we have to file this incident reports in institution computer or document it using an electronic form. Paper form may be completed or filed. If it's it's a computer document, then we have to use it in an electronic form, or if it's a paper document, it has to be completed and it has to be filed. So that's about incident reports. And when should be an incident report should be taken, and some examples are accidental omission of prescribed therapies. So I was supposed to give any particular medicine, or I was supposed to give any treatment to a patient, and I accidentally omitted it, and that is going to affect the patient's treatment therapy or treatment regimen. So that's an accidental omission. Even if it's an accidental omission, we have to that we have to report it, or we have to make an incident report on it. Circumstances that led to injury or a risk for client injury. Okay, anything that has led to injury or a client, anything that is in risk for a client injury. Okay, so we have to even state that. And any client falls or medication administration errors or a needle stick injury, and that's very common. And procedure related to equipment related accidents. A visitor who exhibits communicable diseases. Okay, if somebody is diagnosed with, or somebody is found to have blisters all over his body, or any rashes or any chicken pox, it can be, this blisters can be a chicken pox. So I have seen that, so I have to definitely write up an incidental report, so that none of the other people is going to affect. So yeah, so a visitor who exhibits communicable diseases should be also regarding to that also we have to write in this incident report. And the next one is a physician's prescription. So what is a medical prescription? So something that the physician writes, or something that's stating the treatments or the medicines related to the patient care, that the physician is going to write that, and that is the physician's prescriptions. Okay. So a nurse is obligated to carry out a prescription except if the nurse feels it inappropriate or inaccurate. Okay. If the nurse is asked to carry out the prescription, okay, it's fine, or it's a duty of the nurse to carry out the prescription. But then if the nurse feels it as inappropriate or inaccurate, then we have to question it, or we have to ask the healthcare provider to we have to just clarify it with the healthcare provider, that is it okay to give it like this, or did you really mean this? Or we have to, whenever there is any clarification, we have to definitely ask the healthcare provider who wrote it, or else will make mistakes, and that can lead to a medication error, and it can definitely keep us into something very serious. Okay. A nurse carrying out an inaccurate prescription, that's what, any nurse who is carrying an inaccurate prescription may be legally responsible for any harm suffered by the client. We cannot tell that time that the physician has wrote it that way, okay, or it's not my mistake. Okay. So if you want any clarification, okay, the physician is definitely going to write that, and if you need any further clarification, you have to get it clarified from the physician. Okay. You don't want to make medication error. The nurse should clarify with the physician an unclear or inappropriate prescription. We have to clarify it with the patient or the physician. Okay. And there are certain things called the telephone prescriptions. So during that, maybe over the telephone, we are going to hear the prescription, or we are going to tell the patient about the prescription. So we have to enter the date, time of entry. Okay. So date and time, the physician is just going to call them, or he might not be available at that particular time. So he's going to call us and tell that, this things or this treatment regimen has to be followed. So then you have to enter the date and time, repeat the order to the physician, and record the order. Okay. So once he is going to tell us this injection ABC, BD at morning 9 a.m. and night 9 a.m. So you have to repeat the order to the physician. Okay. The physician will tell you once, and then you have to repeat it back to the physician, and then record the order. Sign the order. Begin with this TO, write the physician's order and sign the order. Okay. So you have to do it that way. You have to sign the order, and the physician needs to countersign the order within prescribed time frame as agency policy. So if our hospital tells you is that you have to get it signed by let it be like 3 hours, then you have to take the physician, you have collected the information, or you have collected the treatment regimen over phone, so that you have to get it signed by the physician. Maybe at that time the physician was not available, and after some time you have to, whenever the physician is available, as soon as possible, you have to get it signed by the physician. And while taking the order, you have to enter the date and time, you have to repeat the order, you have to sign the order, and you have to even you have to sign the order, and the physician will come after some time, and then he will countersign the order. Okay. So yes, but then you have to mention that is a telephonic order. Okay, so that anybody who sees the order can understand by seeing the TO, that's a telephonic order. All right, and the components of a medication prescription. This is again an NCLEX favorite. I remember while I take my NCLEX exam, this prescription was the first question that I had, and I was a little confused. So you don't want to get confused, so I've put it. and you have to, read it thoroughly and learn it, and you don't want to, get confused. Yes. So the date and time the order was written. Okay. The date and time the order was written. The medication names. Okay. And the medication dose. The route of administration. Frequency of administration. And the physicians or healthcare providers' signature. Okay. The date and time. Okay, what date and time, or the physician is ordering it now. Okay, and then he have to write today, this date, 6th of June or something else, and then the time 3 p.m. and that should be there in the prescription. And the medication name, of course, that's a prescription containing a medication, so the medication name should be there, and the medication dosage, it's 3 mg or 5 mg or 500 mg, that has to be written. And the route of administration, IV, IM. Okay, so in my question it was like this, it was written like this, IM and IV. Okay, actually I didn't notice that option first, because when it comes like this, we are not going to, sometimes there will be a bar in between. Okay, so my question was, which all options requires clarifications with the healthcare provider? Okay, sometimes when it comes like this, yes, when it just comes like IM and IV, it was written like this. Okay, this is medicine, IM, IV. So I didn't notice it at first, because it just meant whether it can be given IM or IV, I meant. But then if there is a slash, then it's fine. But if there is not, this thing is not there, then it's wrong. Okay, we need a clarification. We don't know what is an if it should be given IM or IV. So always read your questions thoroughly and answer them. And by God's grace, at the end, I have seen that and I have marked that. All right. Anyways. So the route of administration should be there, and the frequency of administration, either it can be, it can be once daily, or it can be BD twice a day, or it can be TID, or it can be Q4 thoroughly. So anything it can be. Okay, every 4th hourly, OD, BD, TID, anything. Frequency of administration, yes, it has put twice. And the physicians or healthcare provider's signature also should be there. Okay. So that's about, so this many things should be there in a prescription. Okay, and yes, you might be knowing about this as a side note. So you might be knowing about this acetaminophen, Tylenol. Everybody use it anytime when you have any ache. So acetaminophen is an over-the-counter drug. Okay, so you should not give it without prescription. Okay, the nurse cannot give any medicine to any other personnel. It can be an employee, or it can be somebody who's working with the patient itself. Okay, so but the nurse can just suggest, okay, if somebody has a pain or somebody has a fever, she can just suggest that, okay, it will be nice if you're taking acetaminophen, or if somebody is having a stomach ache or something else. So we know acetaminophen is a fever reducer and a pain reliever. So if any time any other employee working with me asks me that, sister, I need some if somebody is asking like, oh yeah, Sandra, can you please give me a Tylenol? I cannot give them. Okay, I'm not supposed to give them. I don't know what are their conditions, or I don't know if they're diabetic, or I don't know any chronic conditions they have, or even sometimes they have an allergy to Tylenol. I don't know what actually they are suffering from. Okay, so the nurse is not supposed to give any other medicine to any other personnel or employee. But I can just suggest, oh, okay, Mr. Smith, it will be fine if you take acetaminophen. I can just tell them, it will be nice if you can take Tylenol. But then I don't know your conditions. What are your conditions? So don't take it. But then you can definitely go for the healthcare provider and then get any medicine you want. Okay, I can just tell them like that. I'm not supposed to give any medicine as such, or give as I like. Okay. And some medicines, like we have to see this, opioids like morphine, hydromorphone, or fentanyl are controlled medications. Okay, these are controlled medications. Opioids are controlled medications. To dispose leftover opioids, we have to take care of them like a small baby. Okay, the nurse must have second licensed practitioner. Okay, me and another licensed practitioner should be there to witness the wasting of the medication. Okay, so a 2 ml morphine was there and I have used 1 ml and the other 1 more ml is there. Okay, I have to waste it. So another licensed practitioner should witness the wasting of the medication. No UPN can witness the wasting. Only another nurse can witness. Okay, no UPN can. No any other UPA can witness the. It's not. Yes. Okay. No any other UPA can witness wasting. Hospital policy should be followed properly. Waste the medication and discard the empty cartridge. So whatever the hospital policy, you have to follow that properly. Waste the medication and discard the empty cartridge. Whenever controlled substance is discontinued, nurse documents date, time, amount used, reason for wasting, and the amount wasted. Anytime this opioids or this control medications are stopped, you have to look for this discontinue. Anytime this control medications are discontinued, you have to see for the date, time, amount used. Total. Maybe it was given for 5 days, 2 ml each, or for consecutively 5 days. Then we have to write we have used 5 cartridge, or we have to use. Or we have used 10 ml, or we have to just state the amount used and the reason for wasting and the amount which we have wasted. Okay, so that's about controlled medications. And the next one, documentation. These are legally required by accrediting agencies that licensing laws and state and medical practice acts. Avoid unacceptable abbreviations. So what's basically documentation? We have to document. The nurse has to document anytime you're performing anything, and these are legally required by accrediting agencies, state licensing laws and state and medical practice acts. And you should not use any unacceptable abbreviations. You have to document it properly, and that's another NCLEX favorite. Maintain privacy and confidentiality of documented information printed from the computer. You have to maintain privacy and confidentiality of the documented information printed from the computer. Do not leave blank spaces on documentation forms. Not blank. It's blank. Do not leave blank spaces on documentation forms. Do not document for others or change documentation for other individuals. You are not supposed to change the documentation for other individuals. So that's all about this legal and ethics. Hope you understood. So what I have to tell you is that it was quite a dry topic, but then nothing worth having comes easy. Okay, so really passing NCLEX or completing a topic is a big deal, and you have to revise it again and again. Once completing, I had an issue that after completing all my all the 18 or 19 or 20 chapters, I used to forget the first chapter. So nothing worth having comes easy. You have to work hard, and you have to definitely, the day you pass NCLEX will be, all the studying will be worth that day. So definitely you have to work hard, and yes, working hard will have an answer someday. So thank you, and let's see with another chapter next day.